Yeah, Arthur, Arthur, you there? Can you put the
Yes, I,
neurosurgery banner behind you? Can you have,
so let
yeah,
me try.
I can send you, let me see if I can send you a
Please
image.
send me on my LinkedIn or
Here, hold on, let me get, yeah, we get this here. Hello, Salman. Can you hear me?
Yes, I can hear you. How are you?
Good. How
Ahmad,
are
good to
you?
see you. Not too bad. Long time no see.
Yeah. Listen, I'd like to introduce you to Atabati. He's working with us. He's from Pakistan. He's working on our dual neurosurgery channel. Ata, are you
Okay.
there? Can you say hi to Salman? You probably, maybe you've met him before. Ata, you there? And he'll be introducing Ahmed, who's going to introduce you.
Sure. Yeah, I know Atta well.
Yeah,
Yeah, hello
Say hi to
everyone.
Salman. Say hi to Salman.
Hi everyone.
Okay.
Atta, assalamu
Walaikum
alaikum. How are
salam.
you? Good to see
I'm
you.
good. Hope all well.
All usual.
Welcome,
Good.
Dr. Alawadi. Welcome.
Welcome.
Good to see you, Adnan.
Good to see you, Doctor.
We start in 2 minutes.
Sure.
Sorry, who will, first of all, I would like to say hi for Professor Salman Sharif and for Prof. Adnan. So who will start first?
Ata's going to introduce Ahmed. Ahmed, are you with that? Are you there, Ahmed?
Sure.
Yeah, Ahmed. Ata's going to introduce you. Okay.
If it's okay, can I go first? I just have another commitment after 45 minutes.
Okay, so
that's-
we want to get started right away, right?
Yeah, thanks.
Yeah, okay, no
Okay.
problem. We can start right now. Okay.
So maybe one more minute to go. Yeah.
Yeah, okay. And Ata, I'm not going to say anything. You just when I go 5, 4, 3, 2, 1, you start. Hi, I'm Ata from Neurosurgical TV. Okay. And then I'd like to introduce Ahmed. Basically, does that sound okay?
Yeah,
To me,
sure.
it's
Ata?
okay.
And we're on a time crunch because Salman has to get out of here. Okay, you ready, Ata? I'll go 5, 4, 3, 2, 1. Then you take it. Okay. Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hi everyone. I'm Ata Bhatti, neurosurgeon and vascular neurosurgeon. On behalf of Neurosurgical TV and Dentist Society, I welcome you all and invite Dr. Ahmad Al Ghanimi, neurosurgeon from Yemen, who is host of today's session. Over to Dr. Ghanimi, please.
Thank you, dear. First of all, let me introduce myself. Here is Ahmed Al-Gharmi. I'm the special assistant to the global president of Dentist Society. It's my privilege and honor to have this distinguished webinar with one of the most is prestigious professor, Professor Salman Sharif, who is the coordinator of the prevention committees 2024 to 2025. He is also the chairman of World Federation of Spine Committee and also past president of World Spine Column Society. He will talk about cervical spine trauma management. It's yours, Professor.
Thank you, Ahmad, and thank you everybody who's here. Atta, good to see you, my dear friend from Neurosurgical TV as well. I think everybody have been really good all along. Let me just share my slides.
Perfect.
Okay, so I'm going to start. Thank you, Walter Dandy. I've been affiliated with them for a long time, in working with them with various things. And it's really my pleasure to be here again. Also with our friends from Yemen and also friends from all over the world. And WFNS has obviously been a big part that I've been involved with. And what we are doing at the moment, getting ready for our main event, which will be in Dubai starting from 30th. So what are the patients who are at risk of spinal cord injury? All patients with sustained polytrauma, unconscious trauma patients, minor trauma with neck pain. Obviously, you need to be worrying about them. And back in 2500 BC, an unknown Egyptian physician accurately described the clinical features of a traumatic tetraplegia and revealed an awareness of awful prognosis with the chilling advice, an ailment not to be treated. So if you look at this paper, is from 1988. Epidemiology, about 50,000 spinal injuries occur annually. Half are located in cervical spine, and 11,000 result in some kind of spinal cord injury. Factors that may lead to delayed in diagnosis, and this is a day-to-day thing that we see in our hospitals. If you have concurrent head injury, if there's altered state of consciousness, poor radiology, and multiple injuries, then you're not sure what to treat first, and obviously then we are dragged away. Somebody has got a chest injury or a tummy injury. Initial management is evaluation, resuscitation, immobilization, extrication, and transport. Not going to go into that. Patients will then be transported in a cervical hard collar and side supports on the hardboard with straps. And why straps? Because we don't want them moving all over the place, but at the same time, the neck and head has to be stabilized as well, so that doesn't move all over the place while patient is being transported. So neurological classification is simple, complete, and incomplete, and everybody knows that. Not going to go into that. Incomplete injury is important for us. Central cord syndrome, anterior cord syndrome, posterior cord syndrome, and Brown-Séquard. Everybody knows anatomical distribution of this, but let me just briefly go through this. So if you've got incomplete spinal cord injury, and you've got these spinothalamic tracts, as well as the corticospinal tracts over here in blue as well. So anterior spinal cord injury, all this anterior bit of the spinal cord is affected. You get bilateral loss of motor, pain, and temperature sensation below the level of injury. There's intact vibration and proprioception because we have this intact dorsal columns, and hyperflexion injury, and is due to disruption of anterior spinal artery. Central cord syndrome, sensory and motor deficits, and you can see you could have both sensory and motor. And upper limbs are affected more as due to our anatomy. And hyperextension injury, it's typical reason for it, classically in older people who have underlying cervical disease. That means they have stenosis. Brown-Séquard, everybody knows. Let's move on. How can we predict spinal cord injury if somebody comes to us? The most important predictor of improved outcome is retention of sacral sensation, S4, S5, especially pinprick, 72 hours to 1 week after injuries. And that really tells us if this patient is ever going to recover or not. Most individuals regain one level of motor function, and most recovery of function takes place in the first 6 months after injury, but can still arise several years later. Predictors, 10 to 15% of individuals with ASIA-A. So we are talking about nearly 1.5 people out of 10, more than one persons out of 10 will end up improving some kind of ASIA-B to D. And 3% of these people will regain functional strength below the lesion of the level. So going up to ASIA-D. So we need to understand that this is important to treat ASIA-A patients because we can give them a new life. Let me just show you. And about half the patients with ASIA-B, where sensory level is spared in sacrum, gain substantial functional strength below the lesion and will convert to ASIA-C to D. All these patients that we are talking about, A, B, we should be aggressively treating them, knowing that they have a good chance to recover. And we know majority of the ASIA-C and D at 72 hours will regain motor function. Recovery below zone of injury. This is again a very important slide. Complete versus incomplete. So ASIA-A, 11% will improve. 3% will go up to ASIA-D and E, meaning mobilizing. So it's important that every ASIA-A patient, we should be aggressively treating early and following the guidelines. Half of the patients with ASIA-B will improve, and they may go up to D or E, and only 1 in 20 will worsen with ASIA-B. We know this. Half of the patients with ASIA-C will improve to D and E, and only 3% will worsen, and majority of D and E will improve. Central cord syndromes, we know that 9 out of 10 patients under the age of 50 will recover ambulations. 41% over 50 will recover same capabilities. Clinical examination is the best indicator for central cord syndrome. This prospective study over 77 patients back in 1997 with acute spinal cord injury, resuscitation, principle of volume expansion, and blood pressure maintenance were applied to maintain spinal blood flow and to prevent secondary injury before any surgical decompression and fixation. So these people were not taking these patients straight away into surgery. They were taking them to intensive care where all this was done. And 66% of patients with complete spinal cord injury improved to at least 1 ASIA grade. And 1 in 3 regained the ability to walk. And 1 in 5 had return of bladder at 1 year. So you can imagine, what we can do for these patients if we give aggressive treatment to them and we make sure that their MAP remains high. What about methylpred? So treatment options for acute traumatic non-penetrating spinal cord injury includes the administration of high dose of anti-inflammatory agent methylprednisolone within 8 hours of injury. In the 3rd study from Brecken, methylprednisolone failed to demonstrate any effect in comparison to placebo. Additionally, due to increased risk of infections, its use is no longer recommended. So remember, with the spinal cord injury, there is no evidence that methylprednisolone works better than placebo. So it was said that reporting of the results of NASCAS-2 were incomplete, leaving clinicians in the spinal cord injury community to avoid or use methylprednisolone in acute spinal cord injury on the basis of faith rather than on scientific consensus. What about glutamate antagonist, riluzole, that many people are using now? It's been shown that there are clear benefits. Riluzole group exhibited a higher rank sum compared to placebo. The greatest treatment benefit occurred in ASIA A injuries. So again, ASIA injuries, we need to try if they are fit to have riluzole, they should have it. It can be given oral or intravenous as well. At 6 months, the probability that riluzole treatment results in overall better outcome than placebo. Riluzole was associated with improved global outcome in patients with severe traumatic spinal cord injury at every score. Surgical intervention in spinal cord injury is a controversial topic. However, the timing of surgical intervention for further needs to have further debate. Based on the biology of a secondary injury in spinal cord, study group looked into it and called it, if we do early intervention, it has to be within 24 hours. And then there was early surgical intervention. There is evidence that surgical decompression within 6 hours of injury will lead to improvement in about 70% of patients by more than 1 ASIA grade. If such a surgery is delayed beyond 6 hours, there's only 12% chance of such improvement. So you can see this difference, 70% versus 12%. So clearly, if at all possible, these patients should be operated as soon as possible. So these are the results of the STASCUS trial. So we suggested that spinal cord injury had significant improvement in early surgery with more or equal to ASIA impairment scale grade improvement in 20% of these patients. The unexpected improvement in a patient with severe deficit could be due to improper initial assessment. So early surgery is beneficial in spinal cord injury patients, if at all feasible. Since their inception of guidelines for acute spinal cord injury, it's been recommended to prevent hypotension, but additionally augment blood pressure for the first week after injury. The current guidelines advise that systolic blood pressure should not be less than 90 at any time, and an average mean arterial pressure we should try to maintain between 85 to 90 for 7 days after injury, unless there are some other reasons for it. Maintenance of MAP values above 85 correlated with improved neurological recovery, and benefit associated with MAP augmentation decreased after a week. Substantial higher rate of neurological improvement in initial ASIA A patients with contemporary management. So the WFNS Spine Committee has a website, and you can find all these recommendations regarding various topics on the spine, and all these are available with recommendations. So all these, for example, are recommendations of how to prevent spinal trauma, et cetera. And then there are papers which are available as well, and you can get them open access. Let me go through the management of subaxial spinal cord injuries. How about locked facets? The severe flexion injuries can result in locked facets, and as you can see here, so we have got this locked facet here with reversal of normal shingle relationship between facets. Facets that have had significant ligamentous disruption allow distraction just short of this subluxation, and these are called the purge facets. The flexion with rotation, if it's on one side, you get unilateral locked facets. If it's hyperflexion, then you get bilateral locked facets. So these are simple concepts that we have, and once we have these concepts, we know how to reduce them or how to treat them. So lateral bow tie sign, visualization of left and right facets at the level of spinal injury instead of the normal superimposed level, as you can see here. Then you know that this side is subluxed. Disruption of the posterior ligamentous complex may produce widening of interspace between the spinous process as seen here. So these are the important signs that you can remember. And the naked facet sign, as you can see here, and it is actually the articular surface of the facet will be seen with the appropriate articular mate, either absent or on the wrong side of the facet. So this should have been in front and it's gone on the wrong side of the facet. And normal facet joint is seen over here. MRI is the best test to rule out traumatic disc herniation, and you can find some kind of traumatic disc herniation in about 80% of these injuries where they have bilateral facet dislocation. How do you manage this facet dislocation? You've got mild unilateral facet dislocation. It's nearly always stable. Conservative treatment could be an option for patients who are not fit for surgery, who are neurologically intact, or external orthosis inadequate for jump dislocated facets. When you've got bilateral, then it's obviously unstable and you need to be surgically stabilized. So close reduction, in majority of the patients, close reductions work very well, and it's performed with monitoring or patient awake, not essential to obtain pre-reduction MRI. And the reason we say that we do not need a pre-reduction MRI, it's not essential because you could be delaying things, one, and during transfer you could cause problems, two. Three, that there are only 2% of these patients who have disc prolapse will have clinically significant problem and majority won't. So that's why MRI is generally not recommended beforehand. Successful in 60 to 90% of facet dislocations, and incident of extruded discs has been reported from 0.7 to 42%, but as said, in majority of the cases, it's not clinically significant. Disc retropulsion, post-traction, open or close. MRI useful, but not accurate in predicting. Controversial use. Disc retropulsion through the disrupted annulus can cause this, and you could have a disc sticking out. And so in patients who are awake, it's possible to do a close reduction. Otherwise, monitoring is essential. Traction. So we all know this, but let me just go through it. If you see here that initial weight is 3 pounds and then 3 pounds per cervical level, and increase to 5 to 10 pounds increment at 10 to 15 minutes interval until desired alignment is attained. And monitoring, if at all, is possible. But again, if you've got patients with complete injuries, then you cannot monitor them. With unilateral facet, locked facets, one may add gentle manual traction towards the side of the locked facet. With bilateral facets, gentle manual posterior tension is applied, and that causes it to go back. Once the facets are purged or distracted, gradual reduction of rates will lead to reduction of these locked facets. So you could have posterior approach or an anterior approach for open reduction. So posterior approach, dangerous in presence of disc herniation. As we said, it's possible, but it's a small chance. Requires 3 vertebral fixation for 1 motion segment. So you end up having another level fusing. Necessary to excise the facets, also requires 3 vertebral fixation. I would only do that if there are locked facets and we are unable to reduce. And for last few years, we have noted that with experience, you realize that you can easily reduce all of them with some kind of maneuvers. So as I just said. Whereas the anterior approach is simple approach, single segment arthrodesis, lower infection rates. So like infection is 1 in 600 versus 2% in posterior approaches, and higher radiographical union rates, better lordotic alignments, and voice changes and dysphagia is the only problem you can have, and that too is temporary. So reduction, a simple reduction, obstruction to reduction already removed. For example, you remove the disc and annulus, then you can reduce it straight away. If not, then interbody spreader technique is simple cloud interbody spreader inserted at 30 to 40 degrees angle into the disc space, and maybe at least 20%, 25% inside, because you don't want to be breaking the edge of the vertebra. And distraction applied with the rotation. And if that happens, as you can see here, if we rotate, then we can move it up and down. And along with rotation, the whole locked facet can be reduced. And vertebra rotates while facets are distracted. If locked facets are disengaged, vertebra realigns, and distraction leads to alignment position. If it's a bilateral dislocation, then you can have spreader right in the middle instead of on the side of the unilateral dislocation. Then if it's unilateral, you put it on the side and then torque applied in the long axis, and then automatically you can reduce it. Vertebral body fracture risk is there if you are too far anterior. So for example, if you just took 2 millimeters or something, you can break the chip over here, which is not the best thing for the patient. And then there's a post technique that you can use, and it's also very simple. So what you do is that you apply bending motion to the unlocked facets. You use convergence placement of the post, so both of them are coming in, and then you distract. And once you distract, automatically this opens up and then is able to release the locked facets. And you can also use a finger to push it and help that as well to go back. And if it's on the unilateral, then obviously you can rotate in and then reduce on one side as well. So these are simple techniques described by Ed Wenzel in his book of biomechanics and trauma. So what about the classification of modified Allen-Ferguson system? So we know that if you have flexion injury, you have unilateral or bilateral facet dislocation. So with compression, you'd have anterior vertebral body fracture with kyphosis, disruption of interspinous ligaments, and you can have teardrop fractures. So imagine you're flexing and at the same time with compressing, then you will have anterior elements to be destroyed. With distraction, you get posterior ligament problems and dislocated or locked facets. With extension, fracture spinous process and possible lamina, and fracture through lateral master facets, including horizontalization of the facets. So with disruption, it will lead to retrolesthesis. In neutral position, you're going to get burst fracture, which is the most common fractures that we see. And with distraction, you have complete ligamentous disruption, which is very unstable and needs to be addressed soon. So let me just briefly take you through to have that concept. So if you have compression flexion injury, you can imagine if you have compressing and flexing at the same time, so you get this compression. So you get anterior inferior beaking, and then you get a teardrop fracture, and then you get retrolesthesis, less than 3 millimeter, and then retrolesthesis more than 3 millimeter. And all these can be addressed via knowing the concept of the injury. So if you have got distraction and flexion injury, so again, if you have distraction and it's flexion as well, so automatically you'll have unilateral, unifacetal dislocation, bifacetal dislocation, and then enterolesthesis more than 50 degrees and complete spondyloptosis. If there's compression extension injury, so you can again think about if it's extension injury, you're going to break with compression the posterior elements. So you get bilateral vertebral arch fractures, and then the extension of the fracture anteriorly, and then spinal alignment is maintained, and here the alignment is not maintained because anterior and posterior columns are disrupted, and you get translation. What about subaxial cervical spine injury classification described by Vaccaro? So it basically has morphology, no abnormality, compression, and you get burst and distraction and rotation and translation. And you get scores for that starting from 0 to 4. And then, so you, for example, you had compression, you had burst, you had distraction, and you had translation. So all of these will lead to different kind of scores. Then you have discoligamentous complex. This we see on MRI, and we see if it's intact or it's indetermined or it's disrupted. So you get score 0, 1, 2. And you got neurological status. Is it intact? Is root ends involved? Complete cord injury gets 2. Incomplete cord injury gets 3, so that you think about this as you need to be aggressive with these patients. Continuous compression, setting of neurological deficits, it's a neuromodifier. You just add 1, and that's how you get scores. And depending on the score, you decide if these patients need to be taken to theater or urgently or maybe treated conservatively. And then AO spine classification, which has helped us a lot along with SLEX to decide how we're going to treat these patients. So this is divided basically into 3 main types. So compression injuries, tension band injuries, and then translation injuries. So if compression injuries are the most common, as I said before, the complete or incomplete burst fractures are common. Split, wedge compression, minor structural features may be treated conservatively. If you have tension band injuries along with that, then you need to see that how are you going to treat that. So depending on if it's B1, B2, or B3, you can see it's just progression of the ligamentous complex opening up and complete physical disruption. Then translation injuries, obviously, as we discussed, different types of treatment are present. Facetal injuries, non-displaced facet fractures, the potential for instability, and floating lateral masses. And then pathological subluxation or purge facets. Then you can have bilateral injuries as well. And then you have algorithm for morphological classification, and neurology and modifiers have come into play. And once we have all these nomenclature, every injury can be decided on the basis of this. Are we going to operate or not operate, or these are minor injuries or major injuries? What about vertical compression fractures, burst fractures? So are the most common with possibility of retropulsion of bone into the spinal canal with neurology. And the classic diving injury is the prototype. Posterior element fractures occurring up to 50% of compression flexion injuries. An important feature is displacement of inferior margin of the fractured vertebral body posteriorly into the spinal canal, and usually it is unstable. Patients are often quadriplegic, although some may be intact and may have anterior quad syndromes. So dislocation with teardrop, you can see here you've got dislocation as well as teardrop in front, and you can see injuries all the way across. Mild cervical compression fractures without neurological deficits, retropulsion of bone into spinal canal are usually treated with rigid orthosis, depending on what are the problems patients has. Stability is assessed with flexion extension views if required, and then you can discontinue the brace if the patient is recovered. More serious compression injuries may require halo or some other form of bracing. If the disc and ligaments are intact as determined by MRI, then an option is to employ a halo. Halo has got significant problems, and we have stopped using halo, at least in our practice. Alternatively, surgical stabilization may be performed if ligaments or disc injury is seen on MRI. If the injury is primarily posteriorly, and that's due to disruption of posterior ligament and facet, and if there is no anterior compromise of spinal canal, then posterior fusion is enough. Severe injuries with canal compromise often require a posterior anterior decompression followed by posterior fusion. So this is algorithm taken from one of our papers where unstable reduced injuries. Then you've got anterior neural compression. If there's no compression, posterior disruption, then you can go and do posterior approach. On the other hand, if it's anterior neural compression, if it's yes, posterior disruption, yes, then you do an anterior approach, and complementary, you can restore tension band from posteriorly. If there's no posterior disruption, you take an anterior approach. Algorithm for management of displaced unstable fractures. So unstable reduced fractures. Then reduction with halo, possible if it's yes. Unstable, then we go on to the chart below. If it's neural anterior compression, no. Then posterior or anterior approach could be there, and complementary posterior approach could be there. If it's unstable and reduced, you go anterior, decompress, and fix at the same time and anteriorly. So WFNS consensus management for traumatic locked facets. In the majority of acute locked facets, less than 3 days, anterior surgical techniques are sufficient to manage successfully. In chronic locked facets, more than 2 weeks, lower cervical locked facets, and no insignificant disc prolapse, and conditions where the anterior approach is not feasible, a posterior approach is indicated. All locked facets should be reduced in an emergency, and surgery should be performed as soon as possible at 100%. WFNS recommendations for subaxial cervical spine classification is that it's safe and effective in guiding the treatment of subaxial cervical spine injury. There is good agreement rate, more than 90%, regarding morphology, neurology, and discoligamentous complex, and the treatment chosen 100% consensus of all the people who voted there. For injuries with SLIC score of less than 3, non-surgical treatment with a rigid collar for 6 to 12 weeks is recommended. For injuries with SLIC score of more than 4, early surgery is recommended. Surgery is indicated for presence of progressive neurology or stable incomplete deficits with significant spinal cord compromise. Anterior surgeries are recommended for significant anterior column injuries. Additional posterior surgeries should be considered for patients who have multi-level corpectomy, for patients with severe dissociated complex injuries. In the management locked facets, a posterior approach is considered. Preoperative MRI is recommended. So as I said to you, that then publications, besides recommendation, publications are also there, which are open access, and regarding how we start from cervical trauma, early management, upper cervical spine, subaxial, etc., etc. And we have all these other topics also covered, and they're all open access and available on website for free. I'd like to invite you, all of you, on behalf of World Federation of Neurological Societies, to join us in WFNS 2025. We have amazing lineup, and we'd be happy to see. And you can see lots of friends enjoying in Karachi, and this is north of Pakistan, and this is Ferry Meadows, where some of our 20 neurosurgeons went up hiking 3-4 years ago. We are doing various workshops. One of this is cervical spine. We'll be looking forward to seeing you all there. Thank you.
Thank you, dear professor, for the amazing lecture. So now I just ask all the attendees to ask any question if they have.
Come on, everybody, don't be afraid.
So I'm sorry that I did not cover odontoid fractures, because I thought then I'd be just going overboard, and also did not cover some other things, which hopefully we can do some other time.
Yeah, there's a question with Faisal Hassan. Go ahead, Faisal. Do you want to speak or you want to text, Faisal? You have your hand raised. Well, you got cold feet. Come on, Sam. I can't believe you're here. They can talk to you. It's hard to talk to you, man. You're busy.
Let me ask Ahmed, what are the facilities like in emergency in majority of the centers in your country?
You asking me? Or?
I'm asking Ahmed.
Oh, okay.
Sorry, I would let Dr. Adnan to answer this question, as he is
Sure.
the most
Yes, Dr. Adnan.
Yes,
aware about it.
as Prof. Salman Sharif, the majority of our in our facilities, we have all facilities for dealing with spinal injuries, which is for the diagnostic CT, MRIs, and also for the operations. All the facilities are available.
Very good. Excellent.
Can I just raise one important issue related to cervical trauma?
Sure.
which is vascular injury. And in the extreme cases, the numbers in different studies are given alarmingly high. Mostly the neurologically positive deficit patients have more chances of having vertebral artery spectrum of injury, right from the dissection to obvious injuries leading to fatalities, mostly in emergency room or before even reaching to emergency room. So I would like Professor Sharif to comment on that aspect, which is very important for GPS.
I think the risk has been rated anywhere from 0.5% to 2%. In our experience, we see one case every 3 years or so. Like we see huge numbers of trauma. And it is rare in our particular scenario. But having said that, the Denver criteria is there for patients who have got spinal injury along with vascular injury. How are we going to address which patients will be addressed, and how are we going to treat them as well? So those are simple criteria. So anybody can go on the net and look up the Denver criteria, which is in our guidelines as well. That for people who've got vertebral artery involvement, how do we go about which investigation will we do, when will we do that? So generally speaking, any patients in which there is a trauma with bilateral subluxation or dislocation or a complex trauma, then we think about getting them. At the same time, there's fracture of the neural foramina, the vascular foramen through which the vessel is going. Then we think about getting CT angio first, and if we see that there is some disruption or there are problems, then we could think about further getting angiogram. But so all those criteria are laid down, but it is rare actually.
Okay,
Right.
Ibi Nawoko has a question. Ibi, go ahead.
Okay, thank you very much, sir. My question is on the approaches being used in management of cervical spine injuries. In a situation, what is there possibility of combined anterior and posterior approaches in cervical injuries? And if yes, what type of cervical injuries could require such approaches?
Thank you, Amy. I think I described that, but I'll go through it again. So basically, majority of the cases where the problem is anterior, we come in anterior, and these are simple anterior single-level surgeries. If for whatever reason somebody has had surgery from front, somebody had thyroid or whatever, or the trauma entails that there are some injuries from front that we cannot come from front, or have a tracheostomy or some kind of other injuries from front where you can't come in from anteriorly, then only I'll go posteriorly. Where I would do anterior and posterior, it's very rare now, because in majority of cases when we reduce it, we put in screws which are large size. So the screws are near bicortical. And if they are bicortical, then I really don't need to do posterior approach. Previously, for last 5 years, we've stopped doing posterior approach, except front and back approach, except for when we know that the problem lies. It's a very complex injury, so more than 2-3 levels are involved, and then you need to support it from the back as well. So it is rare that we do that, but generally we are able to do everything from front now. So only in complex injuries, I do front and back. Once you're comfortable, you're experienced enough, you should be able to do it only from one side as well, because these patients, you need to wait until they get better, and so give them the minimum time in theater. That would be the best possible approach.
Back to you, Ahmed.
Yeah, thank you, sir.
Thank you.
Okay, if there is any question anymore, so I can go ahead with the next presentation. So is there any question else?
So I'm grateful. Thank you. I apologize that I have to leave, but I'm looking forward to seeing you all. And Adnan, hopefully I'll catch up your talk on the net.
Okay.
Thank you.
Thank you. See you,
Thank you,
Doctor.
dear professor. Thank you.
Thank you.
We
Thank you,
also-
everybody. Bye-bye.
Bye-bye.
Well, now, if you permit me, I'm gonna go forward with the next speaker, Dr. Adnan Alawadi. He is the Dundee Yemen Neurosurgeons chapter president. He is also considered the #1 spine surgeon around Yemen. So it's yours, dear professor.
Thank you, Dr. Ahmed. I will share my screen. I will speak about the cervical myelopathy, when and what surgery can be done for this patient. I know this topic is very complex topics, and it's have multiple differential diagnoses, but we will be speaking about the spondylitic cervical myelopathy alone. I depend on my lecture for these four legend books from the AO Spine and from the WFNS Spine Committee book and Greenberg and Degenerative Cervical Myelopathic Radiculopathy book. We'll go through the introduction and all these topics one by one. First of all, for describing the topic of cervical myelopathy, we will define it as disorder and pathological change in the spinal cord, which also an age-related degenerative osteoarthritic change of the disc and facet, ligamentous, and connective tissue of the cervical spine, resulting in myelopathy. Myelopathy occurs as a result of functional impairment of the spinal cord. In the other hand, the radiculopathy results from the disturbance of the neural activity within the spinal nerve roots. Myeloradiculopathy is a combination of the both subjects. You see my screen or?
Yes. Yes, we do. It's on the introduction page. Okay, it fell off now.
It's gone or what?
Okay, go back onto your, okay.
Okay.
Okay, yes, it's back on.
Okay. The most common cause of cervical myelopathy is spondylolytic myelopathic change, which is explained as the most common causes of non-traumatic spinal cord injury, resulting in a high rate of functional disability with decreased quality of life. Due to the unique pathology of the cervical spondylolytic myelopathy is predominantly a disease of an elderly. OBLL will considered as one of the major causes of the spinal myelopathic change, which to be discussed in other topics. 9% of individuals more than 70 years of age had clinical significant cervical spinal stenosis, with about 25% of cases developed myelopathy within 44 years. Patients with the spondylitic cervical stenosis without myelopathy who have T2 signal change on MRI are an increased risk of developing myelopathy in a long term, about 1 year. And also more than 75% of cases with cervical spondylitic myelopathy, there is progression either in stepwise fashion in 1/3 or gradual progressive in 2/3. In some series, the most common pattern was that of an initial phase of deterioration followed by stabilization that typically lasts for years and may not change after it. Others disagree with such a benign outlook and cited that over 50% of cases continued deterioration. Sustained spontaneous improvement is probably rare. Long-standing myelopathy with severe stenosis over many years may cause irreversible deficit due to necrosis in gray and white matter. There is evidence suggesting that clinical stability may be expected in patients under the age of 75 years. The spine, age, cervical disc degenerative progress lead to both anterior and posterior osteophyte formation and ligamentum flavum facet hypertrophy. These processes frequently result in narrowing of the spinal canal and subsequent compression and myelopathic change. For the anatomy, as Dr. Prof. Sulaiman Sharif already described the anatomical section of the spine cord. This is a simplified composition of the anatomy of the spinal cord, showing the bone, disc, and ligamental hypertrophy, disc degeneration, and spinal cord injuries. For the pathogenesis, we describe as the causes of the myelopathic change. We have compressive and non-compressive and other. For the compressive myelopathic change, which caused by narrowing of the spinal canal and spinal cord compression, detected by radiological investigation. For non-compressive myelopathy, we have no pathological compression of the spinal cord, such as spinal cord infarction, inflammatory autoimmune, or rheumatoid arthritis. In other causes like AVM, vascular malformation, or deer fistula can cause myelopathic change. Direct cord compression between, as we said, between osteophyte bars and hypertrophy of or folding of the ligamentum flavum can cause the myelopathic change with repeated trauma. Ischemia due to compression of vascular structure also result in myelopathic change. Also, repeated local trauma by normal movement, flexion or extension of the spine related to the frequent cord injuries lead to the myelopathic change. The other postulated pathogenesis of the myelopathic change is loss of stability, which may result in myelopathic change. This loss of the stability may be loss of clinical stability or biological stability. In AO spine classification, the prospective and the multicenter study from the global cohort was analyzed to define the consultation of disorder presented in the patient with the myelopathic change. They have represented, they have more than spondylitic change of 90% and combined ligamentum flavum hypertrophy in 50%. Single disc pathology, spondylolisthesis, and OBLL were presented in approximately 10%. This is the diagram showing the pathogenesis of myelopathic change with, from the compressive view. Compression lead to ischemia and neuronal degeneration or endothelial cell damage, which both go to the result in inflammatory or disturbance in the spinal cord barrier, which lead to upper limb dysfunction and guide deficit and spasticity. Clinical presentation is subtle and include coordination guide abnormalities. Patient may complain of difficulty of motor tasks such as buttoning of the shirt or zipping of their trousers. Severe myelopathy is characterized by neck pain, extremity weakness, distal extremity numbness, spasticity, and guide disturbance, which can be represented in patient in myeloradiculopathy, which is radiculopathy, nerve root compression, and also spinal cord compression, which result in myelopathy. Also, they can be presented with pain and paresthesia, guide disturbance, ataxia, and cervical pain and mechanical sign are uncommon in cases of pure myelopathy. We can see in motor change, we have upper or motor neuron lesion. Areas motor finding are typically weakness in the triceps, hand intrinsic. There may be wasting of the hand muscles, slow, stiff opening and closure of the fits. There is often proximal weakness of the lower extremities. For sensory disturbance, it may be minimal. When present, often radicular in distribution. It may be a glove distribution. Lower limbs often exhibit loss vibration sense. Compression of the spinocerebellar tract may cause difficult running. Some patients may present it with prominence of the posterior column dysfunction, which impaired joint position sense and 2-point discrimination. Reflexes, we will see that about 27 to 87% reflexes are hyperactive at a varying distance below the level of stenosis. Colonus, Babinski, and Hoffman signs may be present. Inverted radial reflex, hyperactive jaw reflex, can be used for upper motor neuron lesion differential diagnosis for myelopathic change. Primitive reflexes, gap and snout or rooting are not reliable localizing sign. Sphincter disturbance, urine urgency frequency, and urine incontinence is rare. Anal sphincter disturbance are uncommon. The 5 clinical syndrome presenting of cervical spondylotic myelopathy are the transverse lesion syndrome, which combined of corticospinal and spinothalamic and posterior cord column, which is the most common, and it's maybe the possibility in the stage of this disease. Motor system syndrome is predominantly affecting the anterior corticospinal and anterior horn cells, and central cord syndrome, branch cord syndrome, and the brachialgia and cord syndrome. Maybe patient presented with non-localizing pain or non-radiculopathic pain and pain not related to the cervical region, which should be included in the differential diagnosis in clinical evaluation of the patient. For grading of the cervical myelopathic change, the most common system used are the modified Japanese Orthopedic Association score and NORC grading scheme. The NORC grade is a non-specific scale, and the modified Japanese scale is a validated and reliable system. Which go now for the modified Japanese score, which have 4 components: the upper extremities, lower extremities, and sensory and sphincter group. But the upper extremities is 5-point included for the movement. The lower extremities with combined motor and sensory disturbance, and the sensory is only described for the upper limb, and the sphincter dysfunction as described from 0 to 3 grades. The score for this Japanese modified Japanese score is 0 to 17, which be classified to 3 groups: mild, moderate, and severe. This is the NORC grade, which also have 6 grade from 0 to 5, which described in each topic. Now we will combine both NORC and modified Japanese orthopedic scale for the 3 group: mild and moderate and severe degree. In severe degree, we the modified Japanese orthopedic scale is about 11 or below, and for the moderate is 12 to 14, and for the mild is 15 or more. For patient evaluation, we have 4 subjects: clinical evaluation, history, and neurological evaluation, radiological evaluation, and other investigation needed to complete our evaluation. First of all, we go for the clinical history, which is important to decide is this related to the cervical or it's non-chronic disease. The clinical history, if insidious, the onset is generally insidious and in nature and is not uncommon for patients to presented with a sudden neurological deterioration. Also, there is a frequent complaint of leg stiffness resulting from imbalance, numbness, and paresthesia, upper and lower extremities weakness. A decrease in the hand dextal is very uncommon, more often and not axial neck pain. Similarly, pain dominate presentation. Sphincter impairment is also relatively common finding in neurological evaluation will depend on ACA standard for examination of the power and sensory examination of the patient, reflexes, and sacral sparing or cranial nerve for differential diagnosis of upper motor neuron or central cause of the patient presenting symptoms. This is the sensor distribution for different level of patient complaint. This is the physical examination of power dependent on the myotome. Physical examination generally leaves sign of upper motor neuron injury. Motor examination may reveal weakness in the extremities, more likely the distal upper extremities and proximal lower extremities. Sensory examination may show numbness. Reflex system may show hyperreflexia. Hoffman signs, sustained colonus are sign of more severe myelopathy. Tone may be increased, characterized of spasticity. Gait may display slowness, stiffness, and broad-based tipping. In case of acute injury and chronic myelopathy, such hyperextension injury and pre-existing spinal stenosis and myelopathy, urine change may be assessed and rectal tone should be noted. For radiological evaluation, we used X-ray film, CT scan, MRI, conventional or dynamic CT myelogram if patient with had a contraindication for MRI. This investigation to assess the alignment of the spine, canal diameter, stability, and key line for the diameter of the spinal canal, sagittal vertebral alignment or axis, osteophyte, OBLL, and cord diameter, cord signal change, and ligamentum hypertrophy, subarachnoid space around the cord. First, we will go for the X-ray, which show here the sagittal alignment of the vertebra, and here which show the key line, which represented the space occupied by the cord, and here is the Harrison posterior tangential line. It is a Blavo ratio for assessing the spinal cord diameter. For CT scan, we read associated injury as well as total suspected fracture, which are not present, and show the osteophyte for the spinal canal if there is OBLL, and another or bony deficit. The MRI is the most common investigation finding or the test needed for cervical myelopathy, and the most common showing is intramedullary change in two-to weighted image, show hyperintensity or hypointensity in T1, which represented infarction. In T2 hyperintensity, it's represented spinal cord edema. MRI, we have conventional or supine position test or in upright or weight-bearing standing and dynamic study, flexion and extension. There is new modalities of spinal tractography and diffusion tensor imaging with the Abrams modalities of direct desecrated ascending and descending fiber tracts. These are generally remain experimental and very clinical. The ability of the MRI to finding a predicted clinical outcome has been extensively studied. The most common investigation and finding is that of the intramedullary T2 hyperintensity signal, and patient with no intramedullary signal change or signal change only in T2 image had an improved outcome compared to the patient with signal change in T1 or T2 and T2. The patient with regression of spinal cord signal change was seen had significant better outcome. The absence of spinal cord expansion following decompression has been correlated with the worse post-operative outcome. The reduced transverse area of the spinal cord with the resultant banana shape cord deformity at the level of maximum compression. MRI had a higher sensitivity in detecting nerve root compression than the EMG. Now we'll describe the dynamic or upright dynamic MRI or the weight-bearing MRI, which also described by the cervical spondylotic myelopathic and ossification posterior longitudinal ligament, which WFNS spine committee, and also by the degenerative cervical myelopathy and radiculopathy book. These new modalities which can do testing of the patient in the spine, in the supine position and semi-tilting position, and also in the standing and upright position. This can be done also in the sitting position, which can show the difference between the supine and the erect position, as we here see in both these figures. Also, this can show the upright position, it change, and this more prominent disc protrusion in the upright position. For the flexion extension view, it can be helpful, as many cases will not show a compression injury or compression for the spinal cord, or only in a dynamic view, in extension, flexion view of the cord. We will see this in a normal position, standing position, with the disc herniation and the compression of the spinal cord. This is in the extension position, which show more spinal cord compression, and this in the flexion position show another compression, and another level below the first one, showing the first picture. An MRI change in the spinal cord have classification, which classification which grading the subarachnoid space obliteration, and to 50% or the percent of spinal cord deformity, or the percent of spinal cord signal intensity. The signal intensity also classified by 4 or 3 major classification, from 0 to 3, as shown as a transverse change in the cervical cord, or as a snake eye, and more circumscribed spinal cord change. The other investigation may be needed in myelopathic change or cervical spondylotic myelopathy is a nerve conduction study, or AMG, which can help in the if there is to differentiate the other causes of spinal myelopathy or spinal cord myelopathy caused by non-compressive pathology. Also, laboratory finding also needed to exclude the other causes. Differential diagnosis. We have a wide range of differential diagnosis for cervical myelopathy or spondylitic cervical myelopathy, from congenital cause to acquired cause as trauma or kyphosis deformity, epidural lipomatosis, and also for neoplastic spinal cord tumor, extradural, intradural, carcinomatous meningitis, also for hematoma or hematological cause, epidural hematoma, subarachnoid hemorrhage, spinal cord infarction, and spinal cord vascular malformation can causes myelopathic change, radiation, and secondary to iodination contrast may cause myelopathic change. The other is metabolic, which may cause myelopathic change, which is subacute combined system degeneration and toxin infection, which include bacterial or viral infection. Peripheral neuromuscular disorder, Guillain-Barré syndrome, and chronic dysimmune neuropathies, and also myopathies can cause can differentiate it for the myopathic change, and motor neuron disease also, including differential diagnosis. As we said before, the myelopathy, we have either compressive or non-compressive, and also other causes of myelopathic change. For management option, we need to answer the following question. What are the management options we have? How to choose the management plan? What is the non-surgical management plan? What is the goal of operation or surgical intervention? What are the surgical approaches for use? Or what can be chosen for each patient? What type of a procedure to be done? A bone graft, perioperative preparation, and operative room special device. Go for the first one. The management option, either we have non-surgical or surgical treatment. How to choose the management plan. For asymptomatic or minimally symptomatic patient with evidence of cervical cord compression, either we have evidence of radiculopathy or we have no evidence of radiculopathy. If there is no radiculopathy, we can go for close observation only, and spinal cord compression only discovered incidental. If there is evidence of radiculopathy with or without abnormal finding in EMG and somatosensory evoked potential or motor evoked potential, we can go for conservative measurement. If it's failed to improve or demonstrated subsequent neurological deterioration, we will go for surgery. In the mild cervical spondylitic myelopathy with the modified Japanese orthopedic scale 15 or more, we can go directly for conservative measurement as the minimal symptomatic patient, and if it's failed or deteriorated, we go for surgery. For the moderate and severe cases which have modified Japanese orthopedic scale of less than 15, we can go for directly for surgery, unless there is a contraindication for surgery for these cases. What is the non-surgical management plan? It's represented by bed rest and collar and oral medication. This oral medication, mostly anti-inflammatory, analgesics, and muscle relaxant, and neuromodulator medication. What's the goal? What is the goal of our operation? Our operation is the main goal for our operation is for neural decompression to address the myelopathy and radiculopathy or pain, to restore or maintain the stability of the cervical spine, to maintain sagittal and coronal balance, and to prevent progression of deformity. There is a strong relation of the surgery to the following pathologies which can be found in the radiological investigation. as this spinal canal stenosis with no myelopathy have only 1 plus strength of recommendation for surgery. Spinal canal stenosis and myelopathic change on MRI or clinical symptoms, also 1 plus. These criteria are also from the WFNS spine committee recommendation. So, what operation do we have? The approaches we have is the posterior, anterior, and combined. For the posterior, we have fusion from C1, C7 fusion, and C1 this fusion can be done C1 lateral mass screw, and C2, C7 in pedicular screw, and or lateral mass screw. From C3 to C7 screw position in maybe placed in lateral. And also for the posterior approach, we have laminectomy with or without fusion, laminoplasty, mesh, and endoscopic decompression. Anterior approach, we have ACDF, anterior cervical discectomy and fusion, cage and plate, and we have anterior cervical corbectomy and fusion. We have hybrid procedure, which is combined of the first two, anterior cervical discectomy or corbectomy with fusion. We have the anterior combined anti-displacement fusion and the oblique corbectomy, and we have cervical disc arthroplasty or combined anterior and posterior approaches. What is recommended in each approach? In anterior approach, it's favorable for anterior cord symptoms, restoration of lordosis, long anterior cord compression, fixed kyphosis, and level 3 or less, and young age less than 17 years, and stable spine or unstable spine can be done, moderate to severe pain. On the other hand, a posterior approach is favorable in posterior stenosis, short anterior stenosis, flexed kyphosis, and neutral or lordotic spine, or if there is a segment of 3 or more levels, elderly, more than 70 years, stable, need only laminoplasty, and if unstable, need fusion. It's important to address the pain in these cases. If there is no pain or low pain, we can go for the posterior. But if there is axial pain, we go for the anterior approach. What are the advantages of anterior and posterior? What is the advantage? In the anterior approach, complete foraminal decompression, patent, and indirect decompression. Indirect decompression by stretching of the ligamentum flavum through disc height restoration. The advantage of the posterior, easy to multiple level decompression, direct decompression of the posterior element, indirect decompression by posterior drift of the spinal cord away from the anterior compression. The disadvantage in the anterior approach is the adjacent segment degenerative, possible dysphagia and hoarseness, visible scar in the front of the neck, possible pseudoarthrosis. The disadvantage of the posterior approach in inadequate decompression for severe anterior compression or kyphosis, extensive loss of rate of movement, and postoperative axial neck pain, possible C5 palsy. Here for the posterior approach, we have cervical laminectomy alone or cervical laminectomy and fusion. In cervical lordosis, if it's 10 degree, we can go for only laminectomy. But if it's less than 10 degree or of lordosis or strike spine, we need fusion. This fusion done by lateral mass or transpedicular screw to be done. If it's the spine is unstable, we cannot do only laminectomy. We need to do laminectomy with fusion. If it is axial neck pain, it's preferred to do laminectomy with fusion. And if this pain is more severe, we can go for anterior. In age, elderly patient more than 70, we can go for laminectomy only for simple operation. And if in younger than 70, we can go for laminectomy with fusion. If there is a comorbidity, we can go only for cervical laminectomy. And if there is no or absent comorbidity, we can do fusion. This is a schematic illustration of decision what operation to be done for cervical spondylotic myopathy. Also from the cervical spondylotic myopathy and ossification of the posterior patella ligament by WNFS spine committee. If there is a normal lordosis 3 level, we can more than 3 level, we can go through laminoplasty or laminectomy with fusion. 1 to 3 level, we can go for anterior cervical discectomy with fusion with or without plate. In kyphosis, if the kyphosis is not reducible, we can go for if it's 1 or 2 level, if we anterior cervical discectomy with fusion. It's more than 2 level, we can go for anterior corbectomy, anterior cervical corbectomy with fusion. If there is patent subarachnoid space on MRI, posterior fusion. If the kyphosis is reducible, we can go for posterior decompression and fusion. In straight spines, more than 3 level, without instability, laminoplasty. If with this instability, posterior decompression and fusion. If it's the straight spine is 1 to 3 level, we can go for anterior cervical discectomy with and fusion with plate. If the osteoporosis, go for posterior approach, axial neck pain, laminoplasty is preferred. The operative preparation for the spinal operation need preoperative planning to decide which operation to be done, what instrumentation to be prepared, position of the patient, anesthesia, and choice of laterality, either to go from the right side or the left side in case of anterior approach as experienced by the surgeon, or depending on upper level or lower cervical level to minimize the injury of the thoracic duct or the recurrent laryngeal nerve, which is the recurrent laryngeal nerve is more common injured in the right side, and for the thoracic duct is more common injured in the lower left side. For the intraoperative electrophysical monitoring, as is clinically showed that it's not recommended in such cases, but it preferred if it's available to be used. Now we'll go for the laminoplasty, which is simply described by opening of the lamina and elevation of this lamina and fixation with the specific plate. This is the laminectomy. Laminectomy can be done by periosteal dissection, posterior approach, as we showing here, and opening the lamina and including the lateral to the medial to the facet joint. Here it shows the position of C1 screw, which can be as lateral mass, the entry point for optimum. It is isthmus or sublaminar, and this is the posterior arch mass screw also with the trajectory. For the C1 is a pedicular mass or bars screw. I prefer the pedicular screw in C2. In C3 to C7 to C6, we have entry point and trajectory for the lateral mass screw, which described by Anne McGrill and Roy Camel. And for the CDF, it's already known. I will describe the anterior corpectomy, anterior cervical corpectomy, which is shown here in the diagram to remove and the vertebral body and to replace it by expandable cage or bone graft. This bone graft may be either autologous from the iliac or synthetic bone. This is the difference between the oblique and the ordinary anterior cervical corpectomy. Here is the anterior cervical corpectomy. Here is the oblique corpectomy. This is the wrong name. Sorry, I'll go back. This is the anterior anti-displacement surgery, which can be done for a long segment for OBLL to release the compression from the anterior side, which implies drilling of the body for a short distance. Then by a bore, we can drill in one side of the vertebral body to the spinal canal lateral to the postovertebral joint. Then we will place the temporary plate in the upper and the lower level with the screw not fully inserted, only for temporary handling the vertebral body. Then we will drill the other side of the vertebra, and finally we will tighten the screw and plate to elevate the part of the spinal compression, the spinal cord. For postoperative management, we need to put a patient in a hard collar for 2 to 4 weeks to reduce the pain and to allow for the fusion. Follow-up radiography, anterior, posterior, and lateral view in the second week, and also in the first, third, and sixth, and in 12 months, dynamic view in 6 and 12 months. We need this X-ray to follow the sign of fusion, which bone trabecula between the graft and the end plate. If there is absent of radiolucence gap between the graft and the end plate, or absent of the minimal motion, less than 4-degree angulation, or less than 3 millimeter translation on flexion extension X-ray. The absence of motion less than 2 millimeter between the spinous process on flexion extension is the most recommended follow-up measurement plane of a sign of fusion or non-union. What's the outcome of surgery in cervical spondylolytic myelopathy? Most often result in an improvement in neurological function. Many patients will not improve, however, and very uncommonly patient will worsen neurologically. Classic conventional wisdom hold that decompressive surgery result in the prevention of preoperative functional status with the preservation of the preoperative functional status, with the goal of surgery being to halt the progression of the disease. On one study involved 81 cases, resulting in a significant postoperative clinical improvement, which was found to plateau at 6 months after surgery. Functional outcome were assessed using the NOR grading system and the modified Japanese Orthopedic Association scale. For the complication, we have specific complication or general complication can be in each approach or procedure. The most common complication were in anterior C5 palsy, transient dysphagia, recurrent nerve palsy, Horner syndrome, non-union, osteoarthrosis, vascular injury, thoracic duct injury, esophageal injury, bleeding, infection, hardware failure. Also in an oblique, we have vertebral artery injury. In laminoplasty, we have cervical cord injury, nerve root injury, and spring back closure of the laminoplasty, CA flake, and urotomy. Cervical laminectomy and fusion, we have instability complication. The presence of a signal on T1 weighted image and a high signal on T2 image, and the presence of cord atrophy on preoperative MRI is a poor or indicator of a poor outcome, as well as a lack of improvement after surgical intervention. Class 3 evidence suggests that the duration of symptom and the possibility advanced age negatively affect outcome in patients with cervical spondylitic myelopathy. Functional outcome assessment. We have the Japanese cervical myelopathic evaluation questionnaire, which is composed of question and their answer, and also they have this application which can be assessed or calculated the result of the evaluation questionnaire. This can be downloaded from their website. This questionnaire involved 5-part questionnaire, which each questionnaire composed of multiple questions, which can be answered and then filled in this questionnaire the pre and post-operative to evaluate the outcome of the patient, which this application can give you the result. Now we will go for the last chapter of our topic is some case examples. First case is a female patient with 68 years old complained of upper limb paresthesia, lower limb stiffness, neurological condition, upper limb score 2, lower limb 2. This according to the modified Japanese orthopedic scale, sensory 2, sphincter 3. Biceps and tricep reflexes are normal, ankle reflex and knee reflex hyperreflexia negative of muscle reflex. Operation for this case, I will see this is the preoperative CT scan, which show severe canal stenosis. And this the preoperative MRI, which show myopathic change to level this degeneration and herniation. We decide to do for her hybrid technique with corbectomy and single level ACDF. This is the post-operative X-ray film. The other case is a 63 years male patient presented with neck pain, upper limb paresthesia and weakness, lower limb stiffness. Neurological assessment by modified Japanese score is upper limb 2, lower limb 5, sensory 2, and sphincter 3, with negative bicep and tricep reflex, hyperreflexia in ankle and knee joint, also negative Hoffman reflex. We do for him CDF, neurological state post-operative 6-month follow-up, show improvement. The Japanese modified score for this case was 12. This is the preoperative MRI, which mild spinal cord compression, and axial MRI show the myelopathic change in the transverse direction grade 1. This is a magnification of the preoperative view. We done for him multiple discectomy and diffusion. Third case is 15 years post cervical laminectomy, male patient, 65 years, present with upper limb weakness, lower limb stiffness, neurological assessment by modified Japanese score show grade 8. The operation done for him with anterior corbectomy and anterior cervical corbectomy and fusion. The neurological state postoperative is stable. There is no deterioration or improvement. This is the preoperative MRI. This is the previous operation laminectomy done before 15 years, which show kyphotic deformity. This is the post-operative CT scan done, expandable cage and plate with the good result decompression of the spinal cord and the restoration of the spine alignment or spine lordotic. The fourth case is male, 85 years, present with upper limb weakness, lower limb stiffness, neurological condition, assessed by modified Japanese score is 11. This is show one of the complication of case deterioration and was diagnosed as white coat syndrome. This is the preoperative MRI, and we decide long segment of anterior pathology compressing the spinal cord. We decide to go for posterior laminectomy, and this is post-operative laminectomy and show spinal cord injury. The fifth case is a male, 56 years, presented with upper limb weakness, also lower limb stiffness, modified Japanese score was 10. The operation done for him was anterior cervical corbectomy and fusion. His neurologically post-operative is stable. This is the preoperative MRI, show myelopathic change. Here in the sagittal view with hyperintensity in T2. This is the axial view, show also the hyperintensity and the cord compression. Also, there is stibbing of the C1, C2, C2, C3, sorry. We decide to go for anterior corbectomy and fusion. The last case is 52 years old man with upper limb weakness, lower limb, also difficulty in walking with the same modified Japanese score, modified orthopedic Japanese score of 10. We do for him anterior cervical discectomy and fusion. This is the preoperative routine or supine MRI. This is the sagittal view. And this is the dynamic view and upright position for the same case, which show more prominent disc protrusion and spinal cord compression and extension and flexion view. This is the differences between a supine MRI and the dynamic or upright standing MRI, which show a significant cord compression in both flexion and extension view. We go for anterior cervical discectomy and fusion without plate. The last case is 60 years male, medical staff. We have total modified Japanese orthopedic scale of 14. He's now post-operative improvement after 6 months of operation. We also go for anterior cervical discectomy and fusion. This is the pre-operative MRI. We show 3 level compression of the spinal cord, mainly anterior. This is the post-operative CT scan. We show 3 level anterior cervical discectomy with good decompression and restoration of the spinal canal diameter. For summary, clinical and radiological evaluation are cornerstone in any diagnosis. Grading the cervical or spondylotic cervical myelopathy according to the Japanese modified score help in planning the management plan. There is no so-called preventive operation for such cases. Age play a role in the operative management for all old age with comorbidity, conservative or minimal invasive intervention or simple laminectomy. Surgical outcome does not depend on the surgery alone. Post-operative physiotherapy and rehabilitation and medical management play a role in the outcome of these cases. Thank you.
Thank you, dear professor, for being with us today and for this amazing lecture. So now I would like to ask all the attendees to, if they have any question, to ask you directly, or even to put or to write down it in question here.
Fasul Hassan has a question. Fasul, can you go ahead? Okay, you have a hand raised, Fasul. Could you please ask your question? Well, on to the next one. I'll try him again. Okay, he may want to come in the panel.
There is a question on the chat box.
Can you hear me now?
Yes, Fasul, go ahead.
Yeah, hi. Hi, Professor. Very nice presentation. It's Mr. Hassan from UK. So, as I said, a very nice presentation, but I have some question regarding the surgical planning. Probably in UK, we are more conservative for surgical management. Like the very first case, you did a hybrid procedure, corpectomy and ACDF. Possibly, I will not do that one. And also in the number 4, an 85-year-old gentleman who had a big posterior decompression with a post-op injury, you left the C2. Did you try to decompress the C2 also? Because if you see the MRI scan, the OPLL is mainly on quite a bit of posteriorly. So you have not taken the lamina of C2 on your decompression. Will you consider taking the C2 lamina?
Yeah. You're right. For the first case, it's not my case. It's one of the cases done in our institute. Yes, I presented this case as a complication of our mistakes. This case need more posterior decompression to relieve the C1, C2 arch above and below. We presented this case as to show the complication which may happen and what to do in the next time for such cases.
Thank you, Prof. Nice presentation.
Thanks.
Well, there is a question. Someone asked it. Is there any MRI protocol to differentiate between compressive from ischemic myelopathy?
Did you hear it?
Both,
He
both.
asked
Yes,
it?
I hear it. Yes. There is in both ischemic and compressive myelopathy, you will see the change in T1, but you will not see it in the T2 hyperintensity. But instead of the compressive myelopathic change, you will see the T2, T1 change if there is edema with ischemia. Also, you will see the spinal canal diameter or the spinal if there is a degenerative disc or there is OBLL or there is some occupying lesion in the canal which may result in canal stenosis. Instead of purely ischemic change, you will not see this change in the pure ischemic change.
Okay, thank you. Any more questions?
Thank you, Professor Alawadi, sharing your experience. So it's something in case number 4, where the severe myelopathy was secondary to almost global dish-like osteophytes or disc complex. So in that case, the outcome was unfortunately vascular injury. So do you think differently retrospectively? What is the better choice, like open flap door laminoplasty with facet in those cases?
I prefer if there is a negative key line in these cases, I will go for anterior, but anterior operation. As you know, if there is a negative key line, there is no space for the cord to be occupied in the spinal canal. And if you do the compressive only from the posterior, you will not get enough space for the cord as it's already attached to the anterior pathology. Here there is a long segment spinal cord compression from the anterior, and it's 100% is OBLL, and I will go for the anterior anti-displacement corbectomy and fusion. It's the preferred operation approach for this case.
Right. And do you use intraoperative monitoring for these cases, neurophysiological monitoring?
No, no,
Okay.
we don't
In
use it.
difficult cases, even in difficult cases. Okay.
They already have
So
a neurological deficit. They already have a neurological deficit. So if you dependent on intraoperative neuromonitoring for somatosensory evoke potential or motor evoke potential, they already have it pre-operative. So they will not change the result of the intraoperative neuromonitoring.
sure, there is a question from Dr. Anand Katkar. Dr. Anand Katkar. Ahmed, can you just see that question?
He asked it. He asked it about facet screw placement. Can facet screw placement be done?
I don't have any experience in facet screw for the management of cervical myopathic change or fusion. I know I don't have that experience to.
Hello, is there any more question, or should we wrap up here, John?
No, that's about it. As far as I can see. Oh, there's one question from Dr. Obaid. Is there
Already
any,
addressed.
yeah, is there any MRI protocol to differentiate compressive from
Already
ischemic?
answered this one.
Oh, okay,
Already
sorry
answered.
about that.
No problem.
Okay, should we wrap up right now?
Sure.
That's all we have there.
Okay, I would like just to thank you, Professor, for being with us tonight and for this amazing presentation. And thank you for you, John, for being with us, and for Dr. Atta, and for all the attendees that participate with us tonight. So thank you all, and
Thank you.
wish you to see you soon.
Thank
Thank
you,
you all.
everybody.
Thank you,
Alan.
John. Thank you, Dr.
Thank you,
Atta.
John.
Thank
Everyone.
you, Dr. Ahmed.
Okay.